Yeah, so starting with COVID-19 is for us the May 2020 when we realized the pandemic hits Europe, and we found out that autopsy were mostly forbidden in Germany. But we started together with Professor Zankov from Basel and ourselves to do autopsy on these early cases of patients with COVID-19. And this is what we realized in those patients at the beginning. So this is really from the beginning of the pandemic that we see in the cross appearance of the lungs a very hypervascularized lung tissue, which is mostly preserved. And what striking was also that you have edema, and that the weight of those lungs were really mostly the doubled weight that we normally found in the autopsy room. What we did is, in this finding, we started to analyze those samples with different techniques, or we wanted to show the effects of COVID-19 on a holistic approach with different imaging techniques, but also with different transcriptomic, but also staining methods. And we started first to understand what is the backside of those lungs if you take a picture of a scanning electron microscope from those lungs. And this is a regular lung. You see it's well preserved. You see the structure like these sponge lungs normally look like with the alveoli, and in the center you find a central airway. Comparing that with COVID-19, you see it's well in line with that what you realize with the cross appearance of those lungs. You see that this is an alveolus itself, which is covered by hyaline membrane. These are these spider-like webs there, covered by some lymphocytes in there. This reflects mostly the finding that you have some alveolar damage in there, but mostly the structure of those alveoli are preserved. And what's the first step for us in pathology? For sure, we do HE staining, and this is where the first lung we analyze. It's a COVID-19 lung compared to influenza, the regular flu we know. And you see that there's a huge difference between those lungs, the first glance. On the right side, you find the diffuse alveolar damage. On the left side, you see a well-preserved lung tissue. You see these different alveoli, and you see really pronounced vasodilatation in those lungs combined with their lymphocytic infiltrate. And this lymphocytic infiltrate is just perivascular. We see that there's something going around with the vasculature in those first lungs, we realized. And this was for us the beginning to do corrosion casting, to do all these steps to understand what is the influence of the virus for the vascularity itself. With its multiplex staining for those lungs to characterize the infiltration of those cells. And you see again, these are the preserved lung tissue with hyaline membranes that are marked here with the arrowheads. And on the right picture below, you find a picture from the autopsy room, again, with their multiplex immune staining. And you see that in those lungs, predominantly we found a T-cell infiltration, which is located perivascular. So this is normally what you see sometimes in transplant patients, sometimes in patients with vasculitis. So there's something going around with those endothelial cells in the lung. And we compared the inflammasome of those patients. So we compared, we did a nanostring analysis of the tissue, comparing COVID-19 lungs with influenza. And you see there's no much overlap between the different influenza types and COVID-19. And if you remember, President Trump said it's like a flu-like symptom in 2020. But this Venn diagram convinced you that there is something different between the different viral diseases. Running high-level ultrastructure analysis by transmission electron microscopy, we realized that the virus destroys the cells by apoptosis. And these apoptosis of the endothelial cells is mostly driven by virus-like particles. You see these virus-like particles also marked here with the arrowheads, which show the replication of the virus itself, which also happens besides other cell types, also in endothelial cells and pericytes. So the first was for us to prove whether there is an infiltration or infection of the endothelial cells and pericytes, because at the first days of the pandemic, it was unclear whether you have a systemic effect of the inflammation due to the virus, or it's an infiltration itself by the virus. And this is a double staining with the first antibody we could get from for the nucleocapsid of the virus, the SARS-CoV-2 virus and CD31. And you can nicely see that there's a co-localization of the virus in endothelial cells, but also in parasites. And this is well aligned for the clinical findings in those days. You remember we had these traumatic thromboses in those patients, mostly driven by the endothelial dysfunction, which was driven by the virus itself. But it was not only a typical thrombosis, which you know maybe from the clinics. It's a special form. It was NETs, so we described it also in the paper that we found out immune thromboses, which were really triggered by these really systematic inflammation in all endothelial cells, in all the parasites. So they have a high level of neutrophil extracellular traps, and these neutrophil extracellular traps are forming really huge clots, which are really doing occlusion and obstruction of the whole pulmonary vascularity. For us, it was important to understand how those interaction between the infiltration and infection of endothelial cells, parasites, and macrophages are well in line with their occlusions you realized, not only in the lung, but also in other tissues. And therefore, we started a collaboration with the European Synchrotron radiation facility in Grenoble, which was the only one which was open during this shutdown time in the pandemic. So the Synchrotron is a huge ring. You know that maybe from the Synchrotron in Switzerland and the Tomcat, the PSI, which is also a Synchrotron source which allows imaging. And in those times, the European one opened with a really high level resolution, and we tried to analyze where all these clots are located in the pulmonary circulation. This was the first shot we did from those explanted autopsy lungs. You see left that's the regular micro-CT based on synchrotron radiation, which has a resolution 1,000 times better than a regular clinical CT scan. And thereby we could do a segmentation of the clotted airways and the clotted vascularity in those COVID-19 lungs. And you see really that, especially in the subpleural space of the basal parts of the lung, you find really a high level of occluded blood vessels, but also occluded airways that are possible there. And that was for us a starting point of a new technique, which brings us now in those days also to other imaging techniques now in clinical routine, also in pathology. That's use of these new synchrotron source based on phase contrast. So this is the highest resolution you actually can get now from explanted autopsy tissue, but also from surgical samples we can get from our clinical department to send there. We get a high-level ultrastructure analysis of tissue. And for us, this was a starting point for a new technique, which helps us now to bridge also histology with radiology, because we can really scan down. It's back. We can really scan down from the macro scale, from those we realize from the autopsy read down to the glomeruli you see here, and the same comparison to histology. So the quality of the virtual picture we see from those synchrotron scans is nearly the same. So there's no comparison. If you do a pseudocolorization of those scans, it's nearly the same, but it's in 3D. And thereby, we try to analyze. If you have in the lung, it's a special situation because you have a dual supply by the vascular system. You have the bronchial circulation, which we call the private vessels of the lung, and the public vessels, which are the pulmonary circulation. And the question was, if you have a occlusion of the public vessels in the pulmonary circulation, what's happening with the bronchial arteries, which are really a supply way to support the vascularity, especially in the subpleural regions. And we found in those scans, in these virtual segmentations of this autopsy tissue, that especially the bronchial circulation did some special features as known as angiogenesis, or blood vessel new formation, which triggers and helps to overcome these clotted vascularity in the lung. Yeah, and this allows us now to do a virtual histology which is really possible to trigger the lymphocytic infiltrate within the alveolar wall, but also into interstitial tissue by just these scans we did. So you see here the nourishing vessel marked here with red, and these hyaline membrane I showed you at the beginning of my talk are also visible via virtual segmentation and reconstruction done from autopsy tissue on from peripheral tissue. So for us, it was clear that COVID-19 is a vascular disease because it affects not only the lung, but also other tissues. And you see that the long-term effects of COVID-19 are also a blueprint of the long-term vascular endothelial dysfunction. This is also a reconstruction of the vascularity in those lungs. Control lung, nicely arborized blood vessels with a certain hierarchy compared to COVID-19, which is a sign of a blood vessel new formation. And the idea was clear. If you talk about blood vessels in a human body, you have more than 90,000 kilometers in your body. If you align all your blood vessels as one single line, and if you just affect 1 or 2% of those 80,000 kilometers, it's clear that the long-term effects are really huge. So how the body deals with these vascular damage, and there was a special phenomenon we described at the beginning. It's the phenomenon of interceptive angiogenesis. So interceptive angiogenesis is recruitment of circulating progenitor cells from the bone marrow, but also from resident progenitor cells in the lung, that you incorporate circulating and progenitor cells into your vascularity, and you do an expansion of the vascularity. And this was a finding just for the beginning of the pandemic. And the finding of interceptive angiogenesis as an aberrant mechanism of a blood vessel new formation, we recently described it also before the pandemic in pulmonary hypertension, in these plexiform lesions, which are typical for CTEPH, but also for forms of ILDs, so lung fibrosis, pulmonary fibrosis, which are depicted here on the right form, and non-specific interstitial pneumonia. We quantified these finding of a vascular new formation in SARS-CoV-2 lungs compared to ILD lungs, so lung fibrosis and influenza. You see that the effect of interceptive angiogenesis as a hallmark of this vascular damage was huge and enormous. So it was nearly 3 times higher or 4 times higher than in influenza, even more higher than in ILD lungs. The comparison of those factors by nanostring. So this is also just a transcriptome of pro-angiogenic genes in those influenza lungs, but also in COVID-19 lungs. You see there's some overlap in this Venn diagram, but there are also very specific genes for those different types of viral infections. The question was clear: what's happening with these blood vessels? Is that just a way to heal these endothelial damage, or it's a long-term effect? And yeah, the question was for sure, what's happening with all the blood vessels in patients that have survived the infection? And our idea was to compare whether these aberrant angiogenesis could provoke also interstitial lung disease. We compared the typical UIP pattern with NSIP and alveolar fibroelastosis, and you see that the long COVID patients really show a very specific form of a very distinct interstitial injury pattern, which is not clear as shown as the UIP or the NSIP pattern. So for us, COVID-19 was more than just a pulmonary disease. It was a systemic disease, which was mostly driven by the vascularity. And you can think about if you have a vascularity, you always need a certain architecture and hierarchy. The people from the Bauhaus design school said always form follows function. And this is in a physiological pattern, so that you have in the liver a very designed structure. In the lung, it's clear that you have alveoli that have a basket-like shape. In the muscle, you have this corkscrew pattern. And in the nerve, it's also clear that these are very, very aligned in parallel. If you compare it now to the pictures we took from COVID-19, you see that these architecture is totally destroyed. In the heart, you find really dilated blood vessels with some obstructive areas, you can see that here, especially on 5 to 4 o'clock. In the liver, the structure is also completely destroyed. You don't can recognize these typical shape we have seen at the beginning. The same was true for the brain, but even in the placenta. So also in the placenta, vascular alteration was very prominent, and we took many of those placentas we got in pathology for the corrosion casting. And we see that here on A and B, this is COVID-19. You have really swollen villi in those placentas from COVID-19 patients. If you do a corrosion casting, you see also interceptive angiogenesis, you see blind ending vessels. And this is totally different what you see in a regular placenta and the third trimester, that the system and the upperization of these villi are preserved. The same is true in COVID-19 hearts. So Jasmine nicely showed that before. We did also a comparison on the same level with myocarditis in COVID-19. We tracked whether there are some, on the level of the ultrastructures, some differences between the different types. And in comparison that, we also applied this new technique of synchrotron radiation, microtomography, and thereby we could also image the process of interceptive angiogenesis here. Nicely, you see on picture F, this incorporation of circulating progenitor cells that are forming this interluminal pillar, this interluminal bridge, which expands these structures. And also beyond that, it's now possible without any additional invasive corrosion casting to do a reconstruction of the cause of the vascularity, but also the cause of the fibers in the heart, to show that there are some effects on the ultimate level of those cardiac tissue of COVID-19 patients who have succumbed to COVID-19. We quantified that, and also there was also very specific profile of those hearts compared to other diseases like parvovirus B19, but also the classical influenza myocarditis. And for us, it's more or less a starting point to see pathology in a different way, to combine also our colleagues from radiology in our diagnosis. You see, this is also a patient succumbed to COVID-19, and you can nicely now do reconstruction of relevant structures in the brain, can focus down to the nuclei there, and you can also image the vascularity very nicely, and thereby you detect also some pre-lesions of plaques within the brain tissue as little pompons that are visible now in these yellowish structures here. And thereby you can really do a spatial orientation of the damage in a whole organ, and this is I think one of the lessons we could learn from the pandemic. For us, to sum up, COVID-19 is more than a pulmonary disease. It's a systemic disease which affects really not only the lung, the kidney, the heart, the brain, and also the liver. So, and we are really looking forward to analyze more tissue to trigger also the long-term effects of COVID-19, because I think in 5 to 10 years, you will see more different aspects of the virus in the long-term aspects of COVID-19. Thank you very much.